who's our speaker today. Dr. Chen comes to us from the Mayo Clinic, where he is an assistant professor in the Department of Laboratory Medicine and Pathology there, and a consultant in hematopathology. He received his MD and master's in China, and then came to the U.S., where he did his doctorate at the University of Kentucky with Dr. Sidney Whitehart. And that's really where he began his love of platelets, where he studied platelet exocytosis. But what really took him to Kentucky, I learned last night, was basketball. So we got to root for a good team here in the state. After finishing his Ph.D., he went on to do AP-CP residency at the University of Wisconsin, and then went to the Mayo Clinic to do a hematopathology fellowship, and has stayed on there as faculty since 2007. He also has done advanced training in electron microscopy here at the University of Minnesota with our own Dr. Jim White, who unfortunately can't make it. He's off in someplace warm and sunny with conflict of schedule, but is sorry that he's missing today's lecture. He's published extensively in the field of platelet biology and platelet disorders and von Willebrand's disease, and also hematologic disorders. He's currently leading a large study to better understand hereditary platelet disorders. And today he'll be talking about the laboratory diagnosis of hereditary platelet disorders, morphologic, functional, and genotyping studies. So welcome, Dr. Chen.
Thank you. Morning, everyone. So it's very pleasant to be here. And almost I have a feeling this is in my mind, it's almost like an in-house talk. The reason why is that we're all Minnesotan. And then I trained here in the basement in Dr. White's lab for a month. I lived in Radisson Hotel for a month, and then now it's changed this ownership to Commons, and then we all wish the winter is done. So let's start with my talk. So today I want to actually summarize what we learned about the rare hereditary platelet disorder in the past 5 years, bring everyone in the room to what we know at this point. So I have no financial relationships to disclose. So today there's three major aims. One is to understand quickly platelet biology, and then how we use the biology actually to categorize hereditary platelet disorders, and apply routine and esoteric laboratory testing to really diagnose rare disease. Hereditary platelet disorder is very rare, so that diagnosis is sometimes very challenging. So before we do that, I just want to test the baseline of what we know in the audience. So we have a 36-year-old, this is all real cases. A 36-year-old man had a significant bleeding history and uniformly giant platelets on his peripheral blood smear. Which of the following diagnoses is unlikely? Biallelic Bernard-Soulier syndrome, monoallelic Bernard-Soulier syndrome, Meihagelin anomaly, Wiskott-Aldrich syndrome, GATA1 mutation-related thrombocytopenia. The last entity, the morphologic feature, was actually coined by Dr. White in this institution. All right, think about that. Okay, second, the feature of a whole-mount platelet transmission electron microscopic study of a patient, which is on the right. See whether I can here. And can be seen in which of the following disorders except A, Hermansky-Putlag syndrome, B, gray platelet syndrome, C, Chediak-Higashi syndrome, D, Wiskott-Aldrich syndrome, E, Parrish-Trousseau-Jacobson syndrome. If I haven't heard the name, it's fine, perfectly fine. I just want to open up the discussion. This is a rare disease. It's okay that we are not very familiar with this. So let's move on. Hopefully at the end of my talk, so I hope that you pay attention, because all of the answers are embedded in the talk. All right, and then, so let's go through the biology and how we classify these diseases. And actually, I tried very hard to use one slide to cover this. So as we know that platelets are actually released from megakaryocytes, they survey the integrity of the blood vessel. So once there's a vascular damage, the exposed collagen is actually going to be detected by platelets through their two groups of receptors. One is over here. So these are the collagen, direct collagen receptors called the glycoprotein 6 and integrin alpha-2 beta-1, or glycoprotein 1A, 2A. Or indirectly, the platelet can interact with the platelet through a complex called the glycoprotein 1B complex, bind to the von Willebrand factor, and the von Willebrand factor bring the platelet onto the collagen. So that's the initiation of the first adhesion of platelet at the vascular injury site. And then because of that signal transduction happens, and then there's a conformation change. This is the study we've done when I was in graduate school, that you can see the conformation change and concentration of the granules into the center of the platelet. And then these granules are going to be released. And then the released granules trigger further secondary signal transduction, and then causing a conformation change of the glycoprotein 2B3A onto of the adjacent platelets. And that conformation change opened up the binding pocket for these two receptors to bind fibrinogen. And now this is the final primary hemostasis platelet to platelet agglutination. This is actually the mechanism we're using in the testing in the platelet aggregation test. So if we follow the steps, each step, abnormality of each step actually cause 4 groups of a platelet disorder. So number 1 is a megakaryopoiesis defect. They're usually patient presented with a congenital thrombocytopenia, surface receptor deficiency like Bernard-Soulier syndrome. Storage pore deficiency is due to the granulogenesis defect or granule release defect. And finally, signal transduction defect, something like thromboxane A2 receptor defect or aspirin-like platelet dysfunction. So now we're done with the biology and the classification. So now we're into the fun part of how do we diagnose this rare disease. So I'm going to walk you through the pre-analytical, which means the clinical observation, morphologic examination, and also platelet function test, and some esoteric testing. So many of these tests you probably are performing here locally. And then I'm going to tell you what we can do actually to help many of the labs when there's a need to do more further esoteric testing. So personally, I felt that platelet testing starts with the patient themselves. So meaning that it is very challenging, however important, to collect and assess patients' bleeding risk and bleeding severity in an objective way. So it is sometimes very difficult for hematologists actually to assess really whether the patient is indeed having a hereditary platelet disorder or the patient deserves a very expensive esoteric testing. So to accomplish that, focusing on the von Willebrand disease in 2005, Vincenzo Italian group actually started a questionnaire study, and then they actually grouped the 12 bleeding symptoms and scored them 0 to 3. 0 meaning absence of bleeding tendency, 3 meaning very severe, and then 1 meaning mild, and 2 meaning moderate. That's a very typical pathology type of classification. And then the beauty of this is at least we now speaking in same language and trying to classify bleeding tendency and severity. The problem of that is the grading is very rough, and then even though it's provided relatively good specificity, however, the sensitivity is poor. To further expand on this questionnaire, a year later, the British genotype and phenotype working group actually focusing on type 1 von Willebrand disease expanded the bleeding score. And that bleeding score, they added 2 more scores. One is +4, one is -1. +4 are given to the patient when they go through, they have to actually go to surgery or transfusion for their bleeding. And then -1 is rewarded to patient when they actually underwent a surgical procedure and then they do not have any bleeding tendencies. And then, however, the drawback of these 2 questionnaires are they're very long to take. Each one of them take about 40 minutes to get the answer. And then quickly, there's a condensed version about 2 years later. And then they eliminated many factors that do not directly contribute to the final score. And then they make it a simple format, like a table shown here. The beauty of that is now it actually, if you do lots of them, actually the time can be shortened into only 5 minutes. Here's a snapshot of the table that we sometimes use to collect the clinical phenotype of bleeding. So it has all of these parameters of bleeding or bleeding symptoms, and then given each individual scores. So, so that's really targeting two things. One is type 1 von Willebrand disease, as indicated here. Another one is all of these validation studies are targeting for the adult patients. And for the pediatric patient, this is a pediatric blood questionnaire. There's not available before the 2009. And as we know that pediatric patient population is very unique from adults because they have very limited life experience with bleeding challenge. And usually they are not telling you the bleeding symptoms. So therefore, they deserve their own questionnaire. So this group, led by Dr. Bowman, actually, they, based on these previous questionnaire, developed the pediatric questionnaire. They actually added more pediatric-related bleeding symptoms like post-umbilical cord bleeding, and also hematoma in the other tissue, especially in CNS, those things into the pediatric bleeding score. And then after all of these years, in 2010, International Society of Thrombosis and Hemostasis put forward the final bleeding score, cover the whole patient population, including pediatric and adult, and then it's an online form. So this way you can actually go online, click, and put in the numbers, and then you get a final bleeding score. So now, once you have the bleeding score, at least you know if you have a cutoff, you will be able to know whether your patient is likely going to be having a hereditary von Willebrand disease or bleeding tendency, or you can use that as a negative predictive value to exclude the patient that might have these disorders.
Are these scores for personal bleeding history only, or also for familial bleeding history?
This is our really targeting for the hereditary bleeding disorders, but the histories are usually personal histories. And then, this is the really the correlation study demonstrating the bleeding scores here on the x-axis, and the y is the likelihood of a patient having von Willebrand disease. And as you can see that the cutoff at 3, you start to have odds ratio greater than 1, that patient might have a bleeding disorder. But keep in mind that all of these are quite nice. However, the endpoint, clinical endpoint, is type 1 von Willebrand disease. It has not been validated for hereditary platelet disorder. So there's always assumption that this might work for the platelet disorder. And then this assumption has been speculated in the group until 2012 or 2013 published by the UK GENOTYPE and PHENOTYPE group. In this study, they recruited 21 normal donors, and then they checked their bleeding score using the ISTH bleeding score, and then they recruited other 79 patients who they have a clinical long history of a primary hemostasis disorder, and they do not have von Willebrand disease or hemophilia or any other diseases, and then they also do not have thrombocytopenia. Among this group, 50% of them demonstrated abnormal platelet function test, and also they have firm diagnosis of platelet dysfunction, and also 50% of them do not have any laboratory phenotype of a platelet disorder. So, but at least they know using the score, they can nicely separate healthy donors from the problem patients. So in a sense that this is a validation study saying that in certain patient population, you can use ISTH bleeding score, which was intended for von Willebrand disease, and use them for hereditary platelet disorders. So now, once we finish the clinical inquiry about patients' likelihood or tendency of bleeding or even severity of bleeding, next, the clinicians can order test. Now, how do we walk these tests through all the way from the basic test all the way to esoteric test? The test start is actually quite simple CBC and blood smear. So nowadays, we all use automated hematology analyzer. The analyzer is really like a flow cytometer. It's analyzing the forward and side scatter. And here is actually a platelet distribution based on platelet size. And then here, the two dot lines are actually the machine used actually to call platelets. As you can see that when the platelets are getting larger, closer to the red cells, they might not be counted as platelets. So when your patient have Bernard-Soulier syndrome or larger platelets, be careful that your CBC count might not be reliable. And then the mean platelet volume is quite useful for diagnosing for actually providing guidance for diagnosing hereditary platelet disorders. For instance, when the platelets are very small or mean platelet volume is lower than 6 centiliters, and then what's called Aldrich syndrome, or a milder form X-linked microthrombocytopenia can be actually hinted by that low MPV. But when the platelets are really large, when they're greater than 12 centiliters, and then usually Bernard-Soulier should be considered, or some variants should be considered. So next question is, once we have the CBC, once we have the abnormal platelet count, or MPV, so what we always need to be, these findings need to be verified by peripheral blood smear. So now the question is, we have all sorts of tubes floating in our laboratory. We have citrate, we have EDTA. So any of these actually going to affect our MPV, whether this MPV actually will be related to age or gender. Actually, recently we just finished our validation study. This is our regular CBC tube, EDTA tube. This is the MPV. And then this is the ACD tube we use also sometimes for a pediatric patient population. We notice that when the tubes actually get older, meaning longer than 24 hours, the platelets swell dramatically. It actually pass the upper threshold of a normal range and becoming abnormal. And then this is actually very important to keep in mind because recently a phenotype-genotype study done by the UK group, they tried to identify the polymorphism that can dictate the microthrombocytopenia. What they did is they collect patients' whole blood, stored them room temperature overnight, tested them the second day night. So their data, I felt that it could potentially be compromised by the swelling nature of the anticoagulant. So that need to be very careful. And then EDTA also can cause degranulation of the platelets. So be careful, we have multiple cases. We received for evaluation, turned out to be 3 days old EDTA tube, and then gray platelet syndrome was called. So that's another thing. For the platelet, there's no great anticoagulant for platelet at all, and our transfusion medicine folks can testify that. So, but the EDTA appear to be the most pleasant anticoagulant, at least from the aspect of MPV. And then we did our normal range study based on our patient population. We have 111 patients, female, male matched as indicated by the colors, and then age group from 18 to 70. We do not see any age or gender difference. So as a hematopathologist, I was puzzled by a discrepancy. As we age, we know that the cellularity decrease. For instance, an 80-year-old gentleman we call usually the comfortable cellularity is about 20. And then we use the same platelet count normal range for all of the patients. So in a sense, we are thinking that once we're getting older, our bone marrow actually have to work harder in order to keep the same, into the same normal range. There's no big, adequate, large population study to address that issue. Until recently, was published last year by the Italian group. Actually, this is a size, it's very impressive size of the study. It's actually 43,000 people based on different age, gender group and control. All of the secondary diseases are excluded. So as you can see that when we age, actually our platelet count start to drop. It's more significant for men than women. So therefore, when we encounter patients, depending on their original baseline, they might actually cross the line of thrombocytopenia and start to become clinically we felt pathologic thrombocytopenic. In addition to that, the same group identified that at different ethnic group or geographic location, actually the distribution of the platelet count differs. So as you can see that if you happen to be the southeast area of Italy, and then your platelet count is a little bit towards the lower side versus the rest of the other ethnic groups. So therefore, if you're practicing in that area, you probably need to adjust the lower threshold of 150 a little bit lower. So these are sort of a very new information. Take-home message is that sometimes we just look at the 150 for the thrombocytopenia, or to our normal range will be 450 for the myeloproliferative neoplasm. But the key thing is actually patient's baseline platelets count. So we, in our validation study, given our small sample size, we do not see dramatic age distribution or age or gender difference of the platelet count. So now, peripheral smears. Peripheral smear is very important to, it's the initial step to identify hereditary platelet disorders. They're usually small, platelets are small. They're smaller than the 1/3 of the red cells. And then be careful that certain patients, when we're using the EDTA tube, there's a pseudocytolytosis, and then the platelet count might not be reliable. And then in addition, you can't see the platelet, so therefore I put a box around them. They could be gray platelet syndrome or artifact due to EDTA. And also, we pay attention to the platelet. They're large. They could be macrothrombocytopenia, and also pay attention to the inclusions. This is a Mehegelin anomaly. The patient might have a mild tendency of bleeding. So the peripheral smear is actually very important as the initial point to investigating platelet disorders. So now, functional test. So the gold standard test, the platelet aggregation study. So this is a very old technology. It's invented in 1962 in London. And this is basically a turbidity instrument linked with a printer. This is the prototype. It's still in exhibition in London. If you have if you visit a Royal Surgeon College, here's the inventor. We will see him again in a later of the talk. Dr. Gustav Born actually developed this assay, and since 1962. This assay has been actually gradually become the gold standard for diagnosing platelet disorders. And then many of our labs are actually using the protocols developed in 70s, 80s. The reason why I put the number of the years is that many of our assays are grandfathered in, meaning they're before the arbitrary line of 1992. So many of the labs we're using the older concentration, older setting of many things. The reason is that it's very difficult to validate these tests. If we want to validate these tests, we have to follow all of the lengthy regulations and everything. So that is a potential hurdle to actually standardize these tests across all of the labs. So there are really two methods available. One is photo-optical, one is impedance. Photo-optical use light, impedance use the electron resistance. So this is a photo-optical is the most commonly used method in comparison to the other. So today I'm gonna only focus on the photo-optic method. So it's quite simple that platelet-rich plasma is actually put in this tube in front of a light source. And when we add different agonists, these agonists are targeting to a particular mechanism of the platelets. And the platelet is going to agglutinate, and then turbidity will decrease. And then we follow the turbidity, and then we can actually get the platelet tracing. So this is an example of a platelet tracing. Start with a baseline, and then arrow indicating the addition of the agonist. There's an initial conformation change, shape change of the platelet, so you might see an initial spike. And then when you interpret this, the initial spike can be quite informative when in certain rare diseases like gray platelet syndrome and the Mehegelin anomaly. Sometimes they have these very robust conformation change in the very beginning. And then followed the first wave of aggregation. And then usually the platelets are just interacting with each other without a significant signal transduction activation, without releasing their granules. And then once they pass the first wave, and then they release all of their granules, and their cytoskeletals actually undergo an irreversible change, and then they move into the second wave of aggregation. But between the first wave and second wave, there's a pause. That some platelets can deaggregate and reverse the aggregation. So these sometimes happen in patients with hereditary platelet disorders. So in our interpretation, we not only should report maximum aggregation as a quantitative variable, but should also report the pattern of the aggregation as a qualitative variable. So here is a busy table. This is just intended for just giving you a reference that how do you interpret for classical cases. These are you can use this table to diagnose pretty much the very classic rare conditions. And for instance, Bernard-Soulier syndrome, you're looking at absence or very markedly decreased aristocetin-induced platelet aggregation. Glanzmann thrombocythemia, you will see across the board deficiency of platelet aggregation, except aristocetin could be normal or slightly decreased. P2Y1 or P2Y12 ADP receptor deficiency, you obviously will see decrease of a platelet response to two concentrations of ADP. And collagen deficiency, alpha-2 beta-1 or glycoprotein 6, you will have deficiency towards the platelet response to collagen, and higher or lower dose. And be careful that I indicated here that lower dose is important, because certain collagen receptor deficiency, you might actually see normal response if you use too concentrated collagen. And then thromboxane A2 receptor or pathway deficiency, we could expect to see arachidonic acid or thromboxane A2 analog, U46619 deficiency. So these are all quite nice, and hopefully are addressing many of the classical cases. But I want to call your attention that we're missing a group of disease called the storage pool deficiency. These patients, the true prevalence is unknown at this point. And then they actually do not have much of a phenotype based on platelet aggregation. So as I said, this is a very old but gold standard method to diagnose platelet disorders. And in the recent years, starting in 2008, there are multiple guidelines trying very hard to standardize this across the labs. Starting in the CLSI guideline published in 2008, this is the one we are all using in the lab. And then later, the North American consensus guideline came out from the NASCOLA consensus meeting, and then put a little bit more concise regulation, not recommendation to the protocols. And then British European group published their guideline. It's called the British Society of Hematology Guideline, further standardized across in the European countries. And then for the international effort, the ISTH finally in 2013. The project started actually back in 2008. And in 2013, they published the international guideline for how to standardizing the platelet aggregation. So we may not realize how divergent we are when we are doing the platelet aggregation. Why we are spending so much time and so many meetings and guidelines trying to standardize this. Let me give you a snapshot of what we are doing internationally. So here is what we are doing. This is the survey taken in the 2009. Here is the 2008 guideline as your reference. And here, as you can see, I put a median and a range of different participants in the survey. And I just give you one example. That when we're doing the epinephrine as agonist, see the range, 0.1 to 1,500. And then who knows whether we're missing something on this end or the other end. So this is actually quite astonishing. to see that all of us are doing the same gold standard test in a vast variety of ways. And this might be a reason why we're missing, in my own opinion, about 50% of the patient with hereditary platelet disorders. And then, because of that, in 2012, published in Blood, the UK phenotype genotype effort group, they're actually trying to streamline the testing by providing a guidance to standardize at least the agonist. So they recommend just using one agonist to test all of the patients, so that at least we standardize this, and then we can further optimize future. And then they did a comparison study using one agonist versus very extensive study, and then they found by using these concentrations, and then they have 90% specificity or sensitivity or agreement to the expert lab using very extensive panel. And then I have to admit that this is a very good effort, but there are some flaws in this study. Number one is that we know that some rare diseases, they actually only can be detected by low concentration of agonist. Second one is I noticed that they used SD for their calculation of a normal range, because they provided a normal range for maximum aggregation. They provided a standard deviation to call the normal range. As we all know that if the best platelet can do is 100%, so the maximum aggregation will no longer be normally distributed. So therefore, it's a skewed distribution. You cannot use standard deviation to call normal range. So therefore, there's a statistical flaw in this study. So therefore, unfortunately, we cannot use this as our normal range. We have to do our own study. So we launched our study. This took about 2 years to finish. Now we recruited, during the process, 111 patients. Our goal, obviously, is 120. We are 9 short. But unfortunately, we exhausted all of our staffs at Mayo Clinic. So the reason for that is we have to exclude all of patients on medications, aspirin, over-counter, herbal, fish oil, all of those. And we actually studied more than this. We studied 300, and then we excluded them. There's 2 purposes. One is that, if we do that, we actually later can do the comparison study to verify, for instance, when patients on hormonal therapy, can we use the normal range for those patients? So therefore, and because bleeding patients, many of them are hormonal therapy. So therefore, we actually, I'm looking forward that the statistician actually do further study to establish a meaningful normal range for our patient population. So now, we feel, right now we think, okay, we standardize the platelet aggregation. What about these very nice PFA 100 test? This test I like a lot. It's a simple, it's just a blood draw, and then press a button and 2 results coming out. The mechanism is in the original patent diagram. So basically, there's a filter here. There's a little hole here, and then the filter is actually a membrane coated with collagen. On top of the collagen, there are either ADP or epinephrine. And then the whole blood is actually forced through this hole. And then because of the high shear and the collagen or other things exposure, platelet is going to aggregate, and then along with the red cells, and then plug the hole, and then give you a closure time. And this device and idea is, again, invented by Dr. Bourne. So we benefit a lot from this study, and then these are the historical studies we're trying to think. This is what we called in vitro bleeding time, but it's actually not. But anyway, a lot of small series study in the past have shown that it has a 100% sensitivity for detecting classic platelet disorders such as Glanzmann thrombocythemia or Narsoulier disease. And then I call your attention that in many of the studies, when we have a clear-cut Hermansky-Putlag syndrome, gray platelet syndrome, the sensitivity of these PFA is still 60%. So we're still missing a group of patients who might have a hereditary platelet disorder. So again, just to emphasize that PFA, I felt is very useful for targeting the primary hemostasis, mainly two defects, platelet and van Willebrand factor. So if you are having in-house a patient with possible acquired van Willebrand syndrome, in patient with multiple myeloma, or in patient with myeloproliferative disorder, patient with underlying cardiovascular disorder, PFA can be very sensitive. And then, again, PFA is not sensitive for storage pool deficiency. So now, these are all routine lab tests. By this point, you think that you're absolutely convinced patient has some sort of a bleeding disorder. You have excluded van Willebrand disease, coagulation factors, Ehlers-Danlos, myeloma, anything. The patient indeed have familial pattern you want to pursue. This is the time actually to consider esoteric testing. So we start with the platelet EM. So there are three methods or three individual tests to address platelet EM study. One is called the whole mount EM. So basically we just put the platelet from the platelet-rich plasma onto the EM grid and look at them under the EM scope. Second one is do the regular fixing and cutting. It's the thin section to look at the ultrastructure. And Buffy-code is trying to look at the inclusion in the leukocytes. And actually the EM for platelet is actually started, established, validated, well characterized here for the past 40 years. And then this is actually started with Dr. Krivet, and as a research project from a medical student, Dr. White, and then to study hereditary platelet disorder by EM, because in those days EM just came out, similar to right nowadays next-gen sequencing just came out. So there's a lot of excitement about that new technology. So Dr. White described the first attempt was a disaster, and then he did not specify what kind of disaster. But I actually had a disaster that when I loaded my first grid into his EM, actually there's a funny sound, and then the whole thing crashed. So, and then he told me it happened to him also. So, so I feel better. So, and then that actually, the experience he further optimized the strategy of the EM, and that 2 weeks of rotation or attempt turned into a lifetime career. And then he characterized during the 40 years, here are the diseases he characterized. And many of them actually have a very distinct EM features, and many of them do not have any phenotype by regular platelet testing methods. So they are, for instance, dense granule deficiency. Hermansky-Putlock syndrome is the prototype disease, but dense granule deficiency can be seen in Wiskott-Aldrich syndrome, Chedek-Higashi, Parrish-Trussell, and or other storage pool deficiency. Alpha granule, the prototype is a gray platelet syndrome, but you can see in other diseases. And then the white platelet syndrome is named after the patient, not Dr. White. He wanted me to specify that. And then X-linked GATA1 mutation analysis, this one actually due to a collaboration with Dr. White, published in 2008. And then finally, there's a rare 1 or 2 case report of alpha and dense granule deficiency. So as you can see, if for all of these, a simple search, PubMed search will be Dr. White, and then that's the year range. So as you can see that really the whole mount, this is the whole mount platelet EM. The goal is actually to visualize dense granules. The dense granules contain calcium, is block the electron beam. So it creates a shadow on the, in the EM, and then we look at the shadow, and then we know there are dense granules. Here is an example of a platelet from a patient with Hermansky-Putlock syndrome or HPS syndrome. You do not see any dense granules. So this test is almost very straightforward. You virtually do not even need a normal range. And however, I've called your attention that without clinical information, for instance, the albinism, it's very difficult to call HPS just by looking at the EM, because this feature is shared by many other diseases, as I listed here. So the EM platelet EM whole mount for diagnosing HPS is the gold standard test for a patient with HPS. This is actually a featured documentary by Donna Appel and her daughter, and they described in the film how they suffer and how they conquer this disease throughout the course. And also they described the many life stories of HPS patients. The prevalence of the disease in US is about 1 per million, but in Puerto Rico is in some area it can be as high as 1%. So because of this, we felt that there's not much available commercial available test available to take care of these patients, to diagnose these patients, especially for the Puerto Ricans when they're needed for these diagnoses. So we actually decided to validate this test. And then another thing is when we encounter these patients, these are very rare, we sometimes run into the difficulty of explaining these to patients. And then we actually, Dr. White came up with a very interesting idea that this is a normal platelet. This is a patient's platelet with a patient with HPS. He tells patient that if a patient's normal, he will say, your platelet just like a chocolate cookie, chip cookie. And then if a patient's abnormal, say, unfortunately, you have a peanut butter cookie. So that way, at least the patients are really understand what's going on, what's that report mean to them. And then here's an example that he is actually selling or giving out these cookies in one of the HPS network meetings. And then last year, he was rewarded. Here's the arrow indicating the normal cookies. And then he was rewarded a gigantic cookie in the last year hemostasis thrombosis research association lifetime achievement award. So now based on that, I need to show this. This Dr. White's favorite platelets, and very cute. And so starting in 2008, I started on staff on 2007. We decided that there's a need in the field that we actually need to validate this test based on our current criteria and regulation to implement this test in our lab. So we actually, this is involved in multiple effort, visit, and like I said, I spent a month in and out in the basement of the pathology department, and then we validate the whole process, and then we learn a lot about how to recognize the dense granules. We published our dense granule calling criteria. And then the dense granules are usually uniform, round, dark, and they sometimes have tails, process, and rings. And then there are certain things they may mimic alpha granule, like dense granule like this. This is actually an alpha granule. And some of thirds or in chains or or some other the fuzzy balls he called, or other things, they're not dense granules. So we need to clarify those and then in order to launch the further study, because once we move into the normal range study, we have to actually have a consensus on what we call dense granules. And then as a result, we starting recruiting 9 labs nationwide to start to standardize across the nation so that all the labs, especially in children's hospitals, will be able to perform the test locally. And then we provide the consensus form to them, the guidelines, what to call, and this is our recent result. As you can see that there's still not the best. We have some outliers, but in general, we in agreement, our median for this image or sample was 8. And then I sent this image to Dr. White, and then interestingly, he got 8. So we are very happy that at least our effort we're in line with his calling. This is our normal range study, and then we did not see gender or age differences. Again, this is our patient N equals to 111. And I noticed 2 things I think is potentially interesting. We know when there's no platelet dense granules, those patients are HPS. I noticed that actually the dense granule range, this is the mean dense granule per platelet range. And then there are 2 ranges that are quite interesting. So between 1.5 to 0, we have a lot of patients. And those patients are not actually have any platelet aggregation or PFA abnormalities. And then they actually, by the book, should be dense granule deficiency, but not HPS. These patients have not been carefully and well studied, well understood. Another patient population is actually on the top. So we do not know, given our test patient population, we do not know if we have too much dense granules, actually we might have a higher risk for coronary artery disease or arterial thrombosis. That has not been looked at in the literature at all, given the fact that we do not have a normal range in the literature. So that, I think, could be helpful. And thin section, we standardized. We cannot really do lots of manual processing nowadays. We standardize that in our lab to do the automated staining process. And then we use thin section to diagnose many ultrastructural abnormalities, such as gray platelet syndrome. And here's our processing thing. Here, I just used the case volume to show you the process of our experience. We started the validation in 2008. We're really focusing on mainly the in-house cases. And then gradually we learn, validate, and put forward the normal range, and then collaborating with other labs. And then something happened in 2012, as indicated by the red bars, are the cases from the non-Mayo site. Actually, in 2012, we started testing for those outside patient samples. There's no, really the trigger was actually Dr. White finally officially retired. And then he closed his lab, and then we actually stepped in to provide the service in a research setting for his patient population. Right now, we're actually providing as a research protocol for 46 national and international hospitals. The farthest place is actually from Germany to recruit the patients, actually do the EM and also genotyping study. And among, so far, a snapshot, we're still doing the analysis. The snapshot of this is that we notice that many of these are actually patients having storage pool deficiency, which actually, as we can see that in the earlier test, the most common missed hereditary platelet disorder are actually storage pool deficiency. So we're glad that we're catching up. A couple of words on flow cytometry. We validated these for 5 years, and gradually we're moving, hopefully this year, to implement the test. The surface deficiency can cause a variety of classical hereditary platelet disorders, just such as Glanzmann's, Bernard-Soulier, and collagen receptor deficiency. In the literature, the field is missing is that, yes, you can do flow cytometry, you can do arbitrary lines on the histogram to call abnormal deficiency, but most of the cases we don't have a normal range. So when we have a mild deficiency, we have no idea. So in light of that, we actually standardized the test using quantitative flow cytometry, either by fluorescent standardization or by copy numbers. And then we actually established the normal range for those things. So we start seeing patients with large platelets, unremarkable platelet aggregation, mild or moderate glycoprotein deficiencies in certain rare patient cases. So now we're, given these lines, now we're actually start to have a better idea of many patients might have this underlying deficiency. So now we come to this, I like this pie diagram, is that as a coag person, I do a lot of interesting research, platelet research, functional studies. We actually coined and established many of the mechanisms by the phenotyping studies, aggregation, PFA, EM, and flow chamber, you name it. But unfortunately, in my opinion, we're only covering 60% of the diseases. I think probably more than that. And there is still 42% based on this study and beta analysis showing that 42% of the patients might have underlying platelet disorder, but they actually all have a normal clinical lab results. So how do we do with those patients? Now we come back to the diagram. So we know the platelets are going through this pathway. We know anything wrong with any of these steps, we will have hereditary platelet disorders. Here are the list. I just gone over what the phenotype study is best for those scenarios. And then when we really look at the true answer, it's actually, I think that there's another variable we can start to investigate. It's actually, we now know that many of the surface receptors are actually due to these genes, or deficiencies are due to the gene mutations. Some mutations can have a phenotype association. Some of them might not have a direct phenotype association, given the limitation of our current setting of the testing or method. And then here are the list of the granule deficiency genes that has been identified so far. And then further, there's the star genes for signal transduction that are pertinent to platelet function has been uncovered to explain some of the bleeding problem patients. And then in addition, patients with hereditary thrombocytopenia genes are being discovered. Many of them, for instance, GATA1 mutation, RUNX1 mutation, not only patients have a lifetime thrombocytopenia, but also patients have risk of a later development of a MDS or AML. So now gradually we're realizing the genes, the targets, or the potential for further genotyping study of these patients. So here, as an example, that these are the relatively well characterized genes that are responsible for dense granule deficiencies. So here, just for HPS, we have 9 genes that can be responsible for the dense granule genesis. And then there's other genes that could also affect the granule genesis. And then some of the mutations, as I listed here, the mutation have more than can affect not only platelets but also other systems. And then I listed Wiskott-Aldrich syndrome, immune deficiency, and MYH9 associated with other things. For instance, if we just look at MYH9, what is the MYH9? We all know about Mayhagelin. It's actually, they're all related to these particular myosin heavy chain 9 gene mutation. Historically, we have read about these weird names: Mayhagelin, Sebastian, Fechner, Epstein, Alport-like. So they're all based on phenotyping anecdotal case reports of rare disease. But now we gradually know that they're all because of one gene mutation. They have a common feature of large platelets, thrombocytopenia. Some of them might have inclusions, so these can be called MYH9 as the prototype disease, but some of them, so as shown here. And then in addition, they might have a renal problem, deafness, or cataracts. So here, gradually we know that genotyping can help us to diagnose many of these diseases, not only for platelet, but also for associated syndromes. And here I list the things that these mutations has been demonstrated in only platelet disorders. One of them is actually recently well characterized now for gray platelet syndrome. This has been a mystery for a long time. This was first, gray platelet syndrome was discovered in 1971, and then was felt to be a gray by the Peripheral Smear review. And then 8 years later, Dr. White in this institution coined that the gray platelet syndrome is due to alpha granule deficiency. And then 20 or 30 years later, and then the gene is, due to the association study, was coined actually to the 3P, chromosome 3P. This is from the NIH group, William Gauss group. And then in 2011, 3 separate labs actually identified the gene is called the neurobeachin-like 2, or NDL2 gene. So these platelets do not have alpha granules. They're pale in peripheral smear. And then they have a mild myelofibrosis. And then they have some distinct bone marrow features. They all due to different mutations at different sites. They might have different phenotype. And interestingly, gray platelet usually have normal platelet aggregation results. So here, just last year in a late-breaking abstract in the ASH, and then now published in New England Journal of Medicine, that a new gene, GFI1B, has been identified in a group of patients with gray platelet syndrome. They also have no alpha granules. They have a very linear megakaryocytes line up in the bone marrow. So these patients this is, I would call the variant number 2 of a gray platelet syndrome. Now we gradually start to understand or start to know the target of this testing. So at Mayo, we initiated, starting last year, to putting together a 104 gene panel to cover all of the coag related genes, not limited to platelets. The reason for that is we want to understand, because if we target coag, just target the platelets, we actually run into a historical pitfall is that we notice that many bleedings is multifactorial. For instance, we felt that many patients with type 1 von Willebrand disease, they might have a polymorphism of platelets. So therefore, their phenotype, bleeding phenotype can be different if they have both. So therefore, we put together this long list of genes, and then we are in the process of doing all of these. There's actually an institution standardized process for the next-gen sequencing reporting in the future. But right now, in COAG lab, we're doing the next-gen central part. We use the targeting enrichment strategy to enrich the targets of the 104 genes and then do the sequencing and analysis. We're going to start with reporting just disease focus, meaning if you want to order HPS, we will report HPS. We'll hold off those other genes until we really understand what's the genotype mean, especially for new mutations. So, and then by having this, it's very, very handy and help we understand, especially the patient's clinical phenotype of bleeding. So hopefully I just walk you through the simplest peripheral smear all the way to nowadays I would call fancy next-gen sequencing arena. So I think that these genotyping is still have 5 years to grow, to learn, and then it will mature. And then this is actually what we will be doing in the next 5-10 years. So in the future, we're thinking that we have a potential actually to build a reference service to service the patient and research by providing a simple test, peripheral smear, CBC count, aggregation, and platelet EM, flow cytometry, and sequencing. And then there will be a incorporative coagulation or platelet dysfunction or platelet defect consultation service in a report, and then to help both clinician and researchers. So now we come back to the question, hopefully that now we all get it. So 36-year-old man had a significant bleeding, and then you see a uniform large platelets. This is actually, I just had a case last week. Patient was labeled with ITP, had an immune suppressive treatment, and had a spleen out. Turned out to be Bernard Soulier. So this can happen. The able to recognize large platelets in peripheral smear is a simple, cheap way to avoid many things for the patient. So what is the answer? What do you think? Yeah, outreach is the one because in contrast to the rest, the platelets are very small. You hardly can see it on the peripheral smear. So this one, common feature, this is a whole mound. We're looking at dense granules. So the outlier is this. So many of these can have dense granule deficiency, except for gray platelet syndrome, they have alpha granule deficiency. Alpha granule can only be visualized not by this method, but by the thin section cutting the platelets. So I have to acknowledge that during the 5 years of validation and research, we tremendously grateful for Dr. White and Marcy, his technician, to help us set it up at Mayo Clinic. Now we have 2 scopes running. We have 8 techs running the service. They also providing service to renal EM. And then William Gao providing the HPS patient pool for us and also genotyping confirmation. And Donna Appel, she is helping us to recruit patients for testing because she recruited many patients and family members because there's an immediate question is what is the heterozygous phenotype? So she's helping us on that end. So we have a very organized, I think, grateful for the leadership in our EM core facility. And flow cytometry was run in special coag lab by 2 technicians. And our secretarial, Nicole, is she's helping me for the paperwork, recruitment, consent form, all of those HIPAA forms. And then DNA next-gen projects conducted and then collaborating with Dr. Pruthi, Dr. Height, and also 2 specialists doing the next-gen sequencing for the study. And I'm very grateful that for your time and this invitation. And at the end of my talk, I still think I'm missing something, and I thought about it. We, like Dr. White, we do have our favorite platelets. And then, so that we said, we called him that our validation by now is complete. So that he's actually now in Mexico, right, in the warm weather. So thank you for your attention. Take questions.
Maybe have time for a few questions.
Yes.
My recollection is that PFA and aggregometry testing are notoriously difficult. You have to do a very fresh draw in the lab. You have to have the patient there in person at a certain time and run the sample immediately and validate it against a normal lab tech sample. Are there any advances in phenotypic testing, or will flow cytometry replace some of that functional testing to make that testing less burdensome?
Yes, so that's one of our goals. Because like you said, for us it's difficult too, because we have 2 other hospitals, and then transportation has been difficult. Based on guideline, 4 hours is the guideline, and the PFA was 2 to 4 hours, or that's the guideline. So it's very cumbersome to actually even comply with the guideline in the cold weather. And then so therefore we are doing the melt-in platelet flow activation panel validation right now, trying to help really the community setting hospitals to bypass aggregation. Most not even bypass, they don't have the test available. So to help them to at least have some the very typical glycoprotein profile or aggregation or platelet to function test done in a referral setting. So that's will be nice. There's another initiative being done in Amsterdam. There's a company are doing platelet preservative thing, and then they are moving into the testing field. The preservative might be some issues with toxicity for a transfusion purpose, and then but for testing it might work. So therefore they are actually contacting me as a beta site to test for if that even works. So there are 2 things going on. So if they work it out, we could potentially do aggregation easier, or we have to do the flow cytometry method. So yes. Yes.
With the next generation sequencing, don't you I mean, when you look at that many genes and you find 3 that you think were abnormal, how do you begin to figure out what is the most contributing? Do they all go to the same metabolic pathway? Do they all, signaling pathway that's the same? To me, it opens a door, but it raises more questions than answers.
Exactly. So therefore, our strategy has been this. So we're going to do the only exon. We're not doing the whole genome. And then the exon we're going to sequence, and then we're going to report the known mutations, meaning the phenotype have been done by either patient or by laboratory testing. And then the best will be both. And then for the unknown mutations, we can try to understand the signal transduction mechanism by the CAG. There's a database for pathway linkage association database. And then we can actually do some tweaking of our current testing, lab testing, to see if we can increase the sensitivity of our assay. Because like I said, we sometimes ignore abnormal results. When we see subtle aggregation deficiency, we call it unremarkable. I wouldn't say normal, but I would say unremarkable. Are they truly unremarkable? I have no idea. So therefore, I think that this has come back to the issue that now with the genotype, I'm not saying the genotype should replace phenotype. I think we're going to 5-10 years, we're going to have a learning period to really do the comparison study with genotype and phenotype together and really understand what's really going on with the patients rather than the genotype. So I think without phenotype, the genotype can be risky. Yes, please.
I take your preservation comments a little farther. As you know, with preservation of platelets for transfusion, there's no agreed upon in vitro ways to assay those in order to project how they're going to do clinically following transfusion. Do you think there's any hope for us ultimately to be able to have some mix of assays that will enable us in the laboratory to do better studies of platelet preservation for transfusion?
That sounds like a good collaboration we can do in the. So we, to be honest, you know, because our focus has been the hereditary disease patients. We haven't looked into with our group, transfusion medicine group, or even your group, to see what we can actually quality control, the quality of the products, right? And then the 5 days, I don't know whether now extended to 7 days shelf life because of the bacteria issue or has been resolved or not, but I do not know whether we can do something to predict some actually products can be extended further. I don't know. Or certain condition we can further improve the shelf life. So those are all interesting potential projects. And
Thank you again.
all right, thank you. Thank you. Thank you. Hi, Dan. How are you?
Good. Good to see you. Just want to say hi.
Yes, excellent. Thank you.
Fun to hear. So you spent all this time here? Yes. Right in this building.